Let's jump right in. Imagine a medical mystery that has literally puzzled doctors and, quite frankly, terrified patients for over 50 years. We're talking about an illness that doesn't just give you one clear set of symptoms. Oh no. Instead, it kind of borrows the absolute worst features of several different autoimmune conditions. It's a master of disguise, and honestly, that's exactly why we call it the chameleon disease.
In today's Explainer, we're opening up the case file on mixed connective tissue disease, or MCTD. We'll be hitting 5 main areas: the overlap enigma, tracking the symptoms, the diagnostic puzzle, evolution and prognosis, and finally, managing the condition.
So what actually happens when one disease wears the mask of 3? It sounds like a riddle, right? But for a patient desperately seeking answers, it's a really frightening, exhausting reality. Their illness essentially borrows features from lupus, scleroderma, and polymyositis. And for the longest time, this overlap left the medical community completely scratching their heads. They were constantly wondering, are we looking at 3 separate diseases at once here, or is this something entirely new?
Let's get right into it with Section 1, the overlap enigma, a master of disguise. Let's trace the history of this whole medical mystery. Back in 1972, a physician named Dr. Gordon Sharp first described MCTD. But actually, instead of settling the matter, his discovery sparked a massive, decades-long debate. Throughout the 80s and 90s, doctors fiercely argued over whether MCTD was just a transitional phase, kind of like a waiting room before a patient fully developed lupus or scleroderma, or if it was its own unique thing. Well, today, that 50-year struggle for recognition is pretty much settled. It is recognized globally as an independent, distinct disease entity.
Now, the definitive proof of MCTD relies on a biological smoking gun, and that is the anti-U1-RNP antibody. When we look at the pathogenesis, the body's immune system basically goes completely rogue. It produces massive levels of this specific autoantibody, which then mistakenly targets and attacks the body's own healthy U1 ribonucleoprotein complex. Identifying this specific biomarker in the blood, that was the massive breakthrough doctors needed to finally separate MCTD from other connective tissue diseases. With the culprit identified, we can now track the trail of clues it leaves behind. Just keep in mind, these symptoms rarely show up all at once. They usually unfold slowly over years.
Which brings us to Section 2, tracking the symptoms, piecing together the clues. Early on, the disease almost always makes its first physical appearance right at the extremities. Patients frequently experience Raynaud's phenomenon. That's where the fingers literally turn white or blue in response to cold or stress, and they develop strikingly puffy hands. This really takes all that complex immunological jargon about autoantibodies and grounds it in a very physical, very uncomfortable daily reality for the patient.
But the chameleon doesn't just stop at the hands. As it progresses, it can trigger a whole array of issues. We're talking inflammatory arthritis and severe joint pain, much like rheumatoid arthritis. We see muscle pain and weakness, known as myositis. Patients also report severe, just debilitating fatigue. In fact, some studies show the fatigue in MCTD is actually comparable to what you see in multiple sclerosis. And then there's this fascinating, though rare symptom, trigeminal neuropathy. It's a highly characteristic facial nerve pain that is remarkably responsive to corticosteroid therapy. For an alert rheumatologist, that's a very specific clue.
Moving on to Section 3, the diagnostic puzzle, trapping the chameleon.
Because these symptoms mimic other conditions and, as we said, kind of just trickle in over a long period, figuring out what's actually going on is incredibly challenging. To lock in a diagnosis, doctors have to rely on established classification criteria. Systems like Alarcon-Segovia prioritize incredible specificity, meaning if those criteria are met, there's a 99.4% certainty of MCTD. Other systems, like Kasawaka, cast a wider net for higher sensitivity, catching more potential cases. But across the board, no matter the criteria, there is one absolute shared requirement, the mandatory serological marker. Without that high-titer anti-U1-RNP blood test, you simply cannot officially trap the chameleon.
All right, let's pivot to Section 4, evolution and prognosis, the long game.
Once a diagnosis is finally made, the very first question from the patient is obviously, what does the future hold? For a long time, skeptics argued MCTD was just a temporary state, but a massive, nationwide Norwegian cohort study completely flipped that narrative on its head. They tracked 1,118 patients over a staggering 17 years. And the results? 71% of patients retained a stable MCTD phenotype. Only 9% actually converted into a different, specific disease like lupus or rheumatoid arthritis. I mean, this data is absolutely monumental because it definitively proves that MCTD is a stable, long-term clinical entity. It's not just a passing phase.
And here's a truly surprising fact that came out of that exact same Norwegian study. Remember those puffy hands we were talking about earlier? Well, it turns out that the early presence of puffy hands is actually the single strongest clinical predictor that the patient's disease will remain stable as MCTD over the long term. It's kind of ironic, right? It's amazing how a simple, seemingly superficial physical symptom can hold so much prognostic power.
Overall, this long-term stability is incredibly encouraging, especially when we talk about life expectancy. With proper treatment, an impressive 80% of patients survive at least 10 years after their initial diagnosis. In the daunting world of complex systemic autoimmune diseases, that is a number that really offers patients a profound sense of relief and hope.
But, and this is crucial, we have to remain vigilant. This definitely isn't a condition you can just ignore once diagnosed, because the disease can silently cause some severe internal damage. The most critical complications usually involve the lungs. Interstitial lung disease, or ILD, affects roughly 30 to 40% of patients, causing permanent scarring. And even more dangerous is pulmonary arterial hypertension, which is dangerously high blood pressure in the lungs. That is actually the leading cause of mortality in MCTD patients. The disease can also quietly damage the heart, the kidneys, and the digestive tract.
So how do we fight back? Let's look at Section 5, Managing the Condition, a targeted takedown.
Because this disease is a chameleon that affects so many different systems, and because, unfortunately, there is currently no cure, treatment isn't just a simple one-size-fits-all pill. Doctors really have to match the medication to the specific manifestation. When it attacks the vascular system, causing those constricted blood vessels of Raynaud's phenomenon, or the dangerous lung pressure of pulmonary hypertension, doctors respond with medications that actively relax blood vessels. We're talking calcium channel blockers and targeted antihypertensives. It's essentially a direct mechanical counterattack.
But what happens when the core issue is the immune system itself going into overdrive, causing massive inflammation, joint pain, and organ attacks? Well, then the strategy shifts entirely to suppression. Treatments escalate based on severity. They might start with anti-malarial drugs like hydroxychloroquine for mild flare-ups. Then they might move to low-dose corticosteroids like prednisone for moderate inflammation. And they'll deploy heavy-duty immunosuppressants if major internal organs are actively under threat. It is a very delicate balancing act. You have to calm the immune system without leaving the patient totally vulnerable to everyday infections.
Ultimately, what we're looking at here is a disease that has finally stepped out of the shadows of its more famous autoimmune cousins. As highlighted by the European Reference Network on Rare Connective Tissue Diseases, the evidence is now overwhelming. MCTD is a distinct, stable entity. Putting a 50-year medical debate to rest is, frankly, a huge triumph. But much more importantly, it gives patients profound clarity. After years of diagnostic confusion, of constantly being told they have a bit of this and a bit of that, they finally have a real name for their chameleon.
Which leaves us with this final, provocative thought to wrap up our explainer. We've successfully unmasked the chameleon. We know its biomarkers, we've tracked its symptoms, and we know exactly how to manage the damage it causes. But as our understanding of immunology and genetics rapidly deepens over the next decade, how close are we to finally moving beyond just symptom management? When will we discover the targeted therapies that don't just manage, but definitively cure this elusive medical chameleon?